Welcome back to Coffee Talk with Mike and Janelle. We are on episode 16, and we realized that we never properly introduced APIC, APIC, Access to Psychiatry Through Intermediate Care. So as a brief intro, I just want to let you all know I am Janelle Van Cleve. I'm a mental health clinician, and I'm also a certified autism specialist. And my background consists of working with social services and residential treatment facilities, also doing work with juvenile justice, and then obviously the most recently, the last 7 or so years with Dr. Cummings, working with developmental disabilities.
Yeah, and I'm Mike Cummings. I'm a child and adolescent psychiatrist by training. I started running adolescent inpatient unit and then worked running a large inpatient system. Moved into the community mental health centers, juvenile justice, adult forensic systems, and then spent a fair amount of time doing primarily administrative work, running a very large hospital-based inpatient, outpatient mental health community chemical dependency system. But we really met while you were working in juvenile justice, and I was doing psychiatric evaluations for the family court system.
Yep, so we were looking to do diversionary work and intervene where appropriate and find out the best solutions for the kids that were coming through. There was a lot of information available, but unfortunately they had been in so many multiple systems that the information was just kind of scattered. So we developed a system to streamline, consolidate, and make appropriate recommendations to the court. And when you got the opportunity for the grant in 2014, you approached me and said, hey, can we do something similar for this population?
Yeah, really, my experience in developmental disabilities was, really, kids and adults, but in the beginning of my career, kids being stuck in the emergency room or being stuck on inpatient units, and by stuck in emergency rooms for weeks, months, sometimes close to a year.
Yes.
When I first took over an adolescent unit, I had a child I eventually discharged after he had been on a unit for close to 2 years, when the average length of stay was about 10 days. And so we were trying to take the model that we created in the juvenile justice system that was really a diversionary one, and apply it to individuals, kids and adults with developmental disabilities. We were lucky enough to get a grant. The University of Buffalo had worked to get a grant from a bunch of local foundations, and initially we were an emergency room diversion program. So if you had come to the psychiatric emergency room, we're trying to prevent you from coming back by creating supports for you, for your family, whether they be, environmental supports, behavioral supports, psychiatric supports, family-based supports, whatever it was, so that you didn't have to rely on the emergency room, and hopefully you didn't have to stay in an emergency room or a hospital for a very long time.
Right, which is a very detrimental place,
Yeah.
and we'll actually capture that whole conversation at a later date. But so 2014, you had proposed this whole grant scenario to me. I did not want to leave my job as a civil servant for Erie County, very safe and secure, but I did. I took the leap of faith, and I'm so grateful I did. And we had outstanding numbers the first year of implementing our thought processes.
Yeah, in the first year, we saw about 125, 130 families. You have to remember, we had no clear program then, so we were kind of making it up as we went along to figure out what worked, what didn't work. The way you got to see us was basically you called a telephone number. It could have been a care provider, it could have been a psychiatric team, it could have been a hospital, it could have been the individual themselves.
Right.
Everything was and almost still remains 100% mobile. So we were going out to people's homes. That was fairly easy in that first year, right? Because we were really centered around the Buffalo, New York area. And so maybe, within a 50-mile radius. So driving back and forth to households were not that difficult. But yeah, as Janelle said, our first year we had about a 40% reduction in hospitalizations, 35% reduction in emergency room visits. And two of the things that, to me really resonate is about 50% reduction in aggression from the identified patient and a 50% reduction in family distress levels, which to me is almost, the most important thing we do.
Very significant.
So we were really excited about that, and we were doing really well. and we had these great outcomes, and people are saying that's great, but
how can we replicate
there's
APEC?
only two of you,
Yeah,
right?
Yep.
And so initially our thought process was, well, we're going to add team members, and we very specifically added individuals based on their skill sets, with the idea that we are going to grow a larger team and then maybe make multiple teams across the state. And we saw a lot more families, and we did a lot of good work. But what we also realized during that time, I think, is we were discovering which types of cases and which types of families our model worked for really well.
Yeah.
And it turned out to be very intense cases.
Yeah.
This is the upper level of individuals with aggression, who are going to have to leave their home, going to have to leave their group home, at risk of arrest.
Yes.
Significant polypharmacy. All the episodes that we've done prior to this are all related to these levels of cases. But what we also found is, as we expanded and we're seeing 500, 600 families a year, that our results were starting to become diluted, and maybe we weren't as effective. So we had to kind of re-gear and think about how we could still take this model that we had built that had done so well in the first year and still get it to a much broader community.
Right. And I think what ended up happening is we were just basically duplicating a lot of work that a lot of other folks were doing, and a lot of other services and supports that are already available. And we honed in on, just as you said, working with these really complex cases that need the attention and need the streamlined care. Break through the barriers and be efficient, and let's look for the best outcomes.
Yeah, and get the entire team on the same page. I think
Yes.
I think cases that we see, in New York State, and of course we see cases outside New York State, and we consult with entities outside New York State, but we're a New York State-based program primarily. In New York State, we'll have a child or adult who's involved in social services, Department of Education, Office of Mental Health, Office for Persons with Developmental Disabilities, Juvenile Justice perhaps, and maybe others as well.
Yep.
And they all have their role, and they all have their documents, and they all have kind of their missions and visions, and yet they're not necessarily aligned with each other.
Right.
And I think what we realize is our best skill set, and Janelle and I, between the two of us, have worked extensively in each and every one of those silos of being able to say, okay, but here's the problem, and I think most importantly, here's the problem as defined by the family or by the individual that we're serving, or both.
For sure.
So this is what's going on. This is where they are. This is where they're capable of being. What are the barriers to getting them there? What services need to be in place? What things need to happen?
Yes.
And that could be anything.
Yes.
I mean, certainly I'm a psychiatrist. Yes, we write meds. Yes, we do those kinds of things. But it's so much more than that. It's really kind of getting all these silos on the same page, in agreement with the family, so that we can take the hard work that each group is doing and make sure it's all moving in the right direction for that person's developmental trajectory.
Absolutely. And it's looking at the whole person, because there's so many aspects to consider.
Absolutely.
It's not just about the disability, and sometimes the disability itself is not even the driving force of the presentation of challenging behavior. So, you got to look at the big picture.
Yeah.
So it's been a long trip. We are on year 7. We're completely sustainable now. We were grateful for our funders initially, but we've moved on, and we've grasped contrast, and we've grasped ourselves, what we do best, and we've moved on with just doing a lot of consultation work with the entities locally and some nationally now.
Yeah, I mean, that's how we really figured out, initially our plan to scale up was by getting bigger, and what we realized is what we really need to do is align ourselves with existing entities who are already affecting thousands, tens of thousands of lives, across New York State and now across the country, and utilizing what the APEC model is to help support the mission and vision of these other groups. So we work very closely with New York START, both in the Brooklyn and Staten Island area, as well as the 17 Western counties of New York State. We're starting to form new partnerships with some groups that work on a national level, and that way, not only can we provide direct care and direct consultation to individuals and their families, but we have a big mission in APEC for education. Part of the reason why we started doing these videos was because we have common themes that happen case after case after case, and we wanted to kind of have a library that families, individuals, clinicians could go to,
Right.
and you know, hopefully see the value in how we approach
Yes.
these individual things. And so it's been a wonderful journey. I mean, you know, it's very far from being over, but it's been wonderful to be able to, you know, be involved with so many different families. And I'll reference the numbers in various of our episodes, but you know, we've done over 3,000 home visits across the state, and many outside of New York State, and you know, are approaching our, I think, our 2,000th family now. That
Yeah.
actually maybe more than that now, and still with really really good outcomes. And you know, it's certainly from a professional standpoint, I learn something new every day from working with Janelle, from working with the families, from working with our current and new partners.
Yes.
So it's academically stimulating, and it's really good work that I think is meaningful and enjoyable. And so, you know, we're blessed to be able to have the opportunity to be part of APAC and to be able to share it with you know, the IDDD ASD community at large.
Yeah. And I think it's valuable information for anyone. You know, our information is geared heavily towards the population we work with, but our information is also relatable to anyone ever. So, with that, I think we've done a good job
Yeah.
kind of
Yeah. We'll have
explaining who we are for the moment.
We'll have more episodes, obviously, on specific topics, but yeah, I mean, in this way, hopefully, when people log on, they say, "Hey, what is this APEC thing?" They'll have
Who's
a
APEC?
better sense
What
of
are- yeah.
exactly a better sense of who we are and what we do, and we look forward to future partnerships. And as always, if you find this information of interest or valuable, please share. Please consider subscribing to the YouTube channel. And if there's topics that people are interested in hearing about, just throw something in the comments, and
Yeah.
we'll be sure to focus
For sure.
on those topics in the future.
Look forward to it.
Absolutely.
All right. Till next time,
APEC out.
APEC out.